We will continue our discussion of the nursery examination here. So here we're going to discuss the examination of the genitals and the anus, as well as the bones and the infant reflexes and the head, eyes, ears, nose, and mouth and throat. So just remember, the purpose of the nursery examination is to identify any abnormalities or anomalies that can impact the infant's current or future well-being. This is distinct from the newborn examination or the initial examination that's done on the baby, where you're getting the APGAR score. That's more for ensuring the stability of the baby after delivery. This is a more comprehensive examination. When you're doing the newborn, the initial examination, you're not so much looking at the skin or looking at the reflexes. You're primarily ensuring that the heart and lungs are working and the baby's perfusing. But in this case, you're doing a more comprehensive examination, and this should be done in the nursery or in the NICU, wherever the baby's at, within 24 hours of birth. So remember, the exam in the delivery room is not a comprehensive physical examination. 20% of all babies will have one or more anomalies, and the presence of one or two or even three anomalies is not unusual, and it doesn't necessarily indicate an illness or pathology. The problem comes when the baby has multiple anomalies, and some of these can be put together, and we call those constellations, like constellations putting together stars, and they make a shape or an illness. And so some of these sequences or constellations of anomalies are associated with various congenital illnesses. So you can think of like charge or bacterial. That would be some examples of where you can have some of these anomalies that come together forming a syndrome. Of course, some of these anomalies are totally pathologic and need to be treated. So some tips for approaching the baby. Certainly you need to clean and warm your hands before touching the baby. One really good way to warm your hands really quickly is just rub your palms together, create some friction. And that really goes for anybody, especially when you're touching somebody's belly. Nobody likes cold hands, so try to warm your hands up. Also disinfect the surface of your stethoscope with an alcohol wipe and allow it to dry. And remember that the baby does not like having the face, eyes, and ears touched during the exam, so try and save that for last, because you don't want to have a crying baby when you're trying to listen to the heart or the lungs. Start your examination with a general observation, looking for any gross anomalies without touching. So this can include things like looking for skin color, listening for breathing quality, looking at the chest cavity. And then remember that your normal vitals are different from adults. So the normal heart rate for an infant is 120 to 160 beats per minute. Respirations are usually between 30 and 60 respirations per minute, and the systolic blood pressure should be between 50 and 70 millimeters of mercury. So that's much different from an adult. Where typically we would expect, 100 to 120 systolic. Then the temperature, this is where babies and adults are common, so 97 to 100.3 Fahrenheit. So the genitals and the anus, first off, you want to check for the patency of the anus. An impatent anus is associated, or imperforate anus is associated with a bacterial complex, and this really needs to be addressed right away. So if there is an impatent anus, if you can't get your finger into the baby's rectum, then you're going to need to call ped surgery right away. But you also want to look for other anomalies that are associated with this bacterial complex. Check the position of the urethral orifice, and this is something that is very difficult to do in girls. So I would expect on the USMLE, if they give you a vignette, it'll probably be in a little boy. Hypospadias is where the urethral orifice is displaced ventrally. Epispadias is where the urethral orifice is displaced dorsally. So, for instance, if you have hypospadias and you pee, then it'll go straight towards the ground. Whereas if you have epispadias, it'll go up. So just as a displacement of the urethral orifice. It can be associated with exstrophy of the bladder. This is where you just have that sort of red shiny medallion right above on the pelvis. and that will usually be diagnosed at birth because that's pretty obvious. With the male genitals, you'll want to check for dissension of the testicles. If you can't feel both testes, feel around the inguinal ligament. If there's a little mass there, that's a non-descended testicle. The female genitals, you can note some clitoral enlargement. This is typically temporary, and it's usually a response to maternal hormones. Sometimes there's a white discharge with small amounts of blood. Again, that's normal. An enlarged bladder can be mistaken for an abdominal mass or vice versa. If you note an enlarged bladder or you suspect an enlarged bladder, you should go ahead and get sonography, and then ultimately you'll refer this to a pediatric urologist, and they'll do a voiding cystourethrogram, and this is typically due to posterior urethral valves. So here's an example of an imperforate anus. Here's Epispadias. So note that this is the head of the penis is here, the foreskin is retracted, and this is the urethral orifice. Epispadias, I couldn't find a really good picture of it, so this is just on the dorsum of the penis. Still midline though. Okay, you look for bones. One of the most important things to do, and you're not only going to do this on your nursery examination, but you'll do this when the baby comes back for follow-up examinations within 2 weeks usually. You'll check for developmental dysplasia of the hip, and this is done by the Ortolani and Barlow maneuvers, where you're flexing the knee, flexing the hip, and then abducting at the hip. And what you're doing is you're putting your finger right, or your thumb, right over the hip, and you're feeling for a click or a thump. And really the way it feels is like when you turn a light switch off or on. It's just that kind of just really subtle click feeling. But in a normal infant, you shouldn't feel anything. And so what this signifies is developmental dysplasia of the hip, and it's not entirely uncommon. You should also ensure proper spinal alignment just by palpating the spines. Check the hands and fingers for webbing, fusion, polydactyly. Look at the feet and toes, particularly with consideration for club foot, and that's common, but this needs to be treated surgically. And then also ensure that there are no absent bones, particularly the radius. That would probably be the most common place for it to happen, but it can also happen in the leg too. So this is the Ortolani and Barlow maneuvers. They're usually done together. There's webbing of the digits. Now the difference between webbing and fusion of the digits is when you have webbing, you have two bones, but the skin is fused together. And remember, early on in fetal development, all your digits are fused together like a duck. But you should get separation before birth, but if that doesn't happen, you'll have this webbing. And if you note this, you should get an x-ray just to make sure that you don't have fusion of the bones. Because if it's fusion of the bones, you're not going to be able to treat that as easily as if there's webbing. If it's webbing, you can just separate these by removing the redundant skin. Here's fusion of the digits, and if you were to get an x-ray of this, the bones would actually be fused together. And this is also called syndactyly. Here's a congenital absence of the radius. So there's no radius here. You can also have congenital absence of the fibula. So fibula here, but not here. And this bowing here, I'm not exactly sure how that happens or happened physiologically, but it's probably just due to the excess pressure because there's no supporting fibula. This is club foot. Okay, so the newborn reflexes. You need to be aware of these, not only what they are, but when they disappear. Because if they don't disappear properly, then there's a neurologic problem. So the first one, and I would say the most important one as far as the test goes, that's most commonly tested, is the Moro reflex. And this is also called the startle reflex. The best way to do this is hold the baby supine. Don't do this, you hold the baby over their bed. So don't hold the baby 5 feet off the ground. But hold the baby supine, support the head, and then allow the head to just drop like a couple centimeters. And what the baby should do is what anybody would do if they felt they were falling. The baby would abduct the arm at the shoulder, extend at the elbow, and spread the fingers. And it's actually kind of cute when you watch the baby do this, but it looks like the baby is startled. And this should disappear by 3 months of age. One good way where this would come up abnormal is if the baby has Erb's palsy. And Erb's palsy is a brachial plexus problem, and the baby will not actually be able to physically move its arm because there's problems with the nerves. So that would be a good example where this would be abnormal. There's other things too that can cause an abnormal Moro reflex. A palmar grasp reflex is pretty simple. You just put your finger in the baby's palm, and the baby should grasp your palm. This disappears by 4 months of age. This will be absent in Klumpke's palsy. Klumpke's palsy is a problem with C8 and T1, and this is it controls the intrinsic muscles of the hand and the wrist flexors and extensors. So certainly the baby won't be able to move their hand if those nerves are impinged. The sucking reflex is pretty obvious. This is put your finger or a nipple in the baby's mouth, and it just reflexively sucks on it. So you can do this, just glove your hand, please. You can glove your hand, put your finger in the baby's hand or your pinky, and you'll be able to feel the baby sucking on your finger. The rooting reflex is just you touch the baby's cheek, and the baby will turn its head towards the side the cheek is touched. The tonic neck reflex, what you do here is passively turn the baby's head to one side, and the baby will assume this fencing position. I'll show you a picture of it on the opposite side that you turn the head to. And then the Babinski reflex is something that you do in adults too. Usually when you do this on adults, I should say all the time when you do this on adults, if it's upgoing, if you have extension, that's considered abnormal. It's considered a spinal cord problem, upper motor neuron problem. Now, in babies, they typically have not myelinated their nerves completely yet, and so you may get an extensor, an upgoing response on your Babinski reflex. That's normal. It's usually after 1 or 2 years of age where you need to really start being concerned. So here's the Moro reflex. All you're doing is holding this baby over a soft surface, letting the baby's head drop a little bit, and the baby will do this cute little thing here. This is the tonic neck reflex, so this is like your fencer position. So you turn the baby's head this way, and it does this thing with its arms. Here's another one. So it's like the baby's holding its sword here, defending itself here. That's the fencing comparison. The Babinski reflex is documented here. So this extensor plantar response is the Babinski sign, the positive Babinski sign. In a baby, this is totally fine if this happens, but you should still document it anyway. On the head, you're going to look for abnormalities of the scalp particularly, and also any kind of bleeding that's happening in the tissues that make up the scalp and the skull. There's 3 of them that you should be aware of. Cephalohematoma is swelling of the head that's within suture lines, and this is a collection of blood between the skull bone and the periosteum. So this is limited by the suture lines, and that is what's going to differentiate it from Caput Succedaneum, where you have, this is a much more superficial collection of fluid, and this can cross the suture lines. So a cephalohematoma is a collection of blood within suture lines, and it abruptly stops at a suture line, and that suture line is typically on the midline. And this can just be observed, but because you have a collection of blood, and that blood will eventually become naturally drained, it can be followed by jaundice. There may be an underlying linear skull fracture. You can get an x-ray if you want to look for that, but it really doesn't matter because a linear skull fracture is going to be treated in a baby just like it's treated in everybody else, and a linear, non-depressed skull fracture is treated by doing nothing. You should never aspirate the blood from the cephalohematoma. This is a common wrong answer on the USMLE that can lead to infection. You really do not want to stick any needle that far into the skull. Caput Succedaneum, as mentioned, is that molding, that cone head that can happen on the baby. I would say this is actually more common than not. This typically happens in babies who are delivered vaginally just because of the pressure from the bones and from the cervix. So this will usually go away in a couple days, but parents are often really concerned about it, especially if it's their first baby. What you have here is a collection of serum and blood superficial to the periosteum, and it's between the subgaleal aponeurosis and the scalp. So this doesn't have any of those suture lines that are restricting it, so it will cross the suture lines. And this is what helps you distinguish it from a cephalohematoma. And this will go away within a few days. The subgaleal hemorrhage is the most emergent of all of these three, and this can be a potentially massive bleed because the scalp, being as well vascularized as it is, can contain a lot. It can hold a lot of blood, and a baby can actually bleed out into the potential space around the scalp. So this typically happens in babies that have vacuum-assisted delivery. 90% of babies who have subgaleal hemorrhages were delivered with vacuum assistant. So this will be noted as a fluctuant boggy mass with overlying bruising, and it may obscure the suture lines as it is superficial to the periosteum. So with these babies, you'll want to monitor them for hypotension or tachycardia. If they do develop hypotension or tachycardia, you should perfuse them with fluids and blood products. So here's the scalp and skull layers. It becomes a little bit more apparent here. You can see this is what makes up the suture lines here. This is the dura mater, and so if you have a here's our cephalohematoma here. This is confined within the suture lines here, whereas a subgaleal hemorrhage can obscure them, but a caput succedaneum is more within the skin and connective tissue. And so this will certainly not be confined by the suture lines. So here's an example of a cephalohematoma. Note that it abruptly terminates at the midline. Here's another one. Is that the same baby? No. This is caput succedaneum. So if you were to turn this baby around, you would see that this abnormality extends across the midline. This is just normal molding of the head from vaginal deliveries. But you would never note this in a C-section. This completely comes from the pressure from vaginal delivery. This is a subgaleal hemorrhage. What you note here is the overlying bruising. So also to do on the head is to gently palpate the fontanelles. The anterior fontanelle should be 1 to 4 centimeters. The posterior fontanelle should be less than 1 centimeter. In some babies, you may palpate a third fontanelle along the sagittal suture, and this is always abnormal. It's associated with various congenital syndromes, particularly the most common, Down syndrome. And then bulging fontanelles are associated with elevated ICP, and this can be noted in any baby that their fontanelles haven't closed yet. So if a baby has meningitis, they may have, or encephalitis, they may have bulging fontanelles. Here's your fontanelles here. So this is the anterior fontanelle, the larger one, and the posterior fontanelle, the smaller one. And then this is the sagittal suture. You may have a fontanelle here if the baby has a congenital anomaly. Okay, so eyes. Babies are born with 2400 vision. That, for us, for adults, would be legally blind. but the baby's vision will rapidly improve within the first couple weeks of life. Now, 2400 vision is just perfect for the baby because they can see within about 9 inches, and that is conveniently roughly the distance from mother's face to mother's breast. So they will be able to see their mother while they're nursing. You can note subconjunctival hemorrhages. That's not uncommon following the stress of birth. Mom will probably have them too from all that pushing. You should examine the external eye here. We're looking primarily at the iris and the pupil. So a coloboma can be noted. This is part of the charge complex. And what a coloboma is just a little notch in the iris. And so it looks like a keyhole. And this is commonly called a latchkey defect. I'll show you a picture of that in a little bit. Aniridia is a severe hypoplasia or absence of the iris. You won't even see the iris. It has visual implications that can lead to blindness and also is associated with Weger syndrome. Weger stands for, I'm trying to remember, Wilms, Aniridia, genitourinary anomalies, and retardation. Hyphema or cloudy corneas will require ophtho consults. And then you also, and this is very, very important, check the red reflexes. A leukocoria, which would be a white reflex, demands immediate attention. The possibilities can be anything from a cataract, which is in and of itself relatively benign, can be cured, to a retinoblastoma, which is a pretty deadly cancer. So this will always require immediate attention. And then the secretions, if there's any secretions of the eye, that can suggest conjunctivitis. And you'll want to go back, look at the mom's torch titers, and see if there's any, if there were any diseases passed down, congenital infectious diseases. So here's a subconjunctival hemorrhage. Note that it stops where the cornea is. Here's a coloboma. So you don't have a round pupil, you've got a more like a keyhole pupil. And this is aniridia. There's no iris here. This would be leukocoria. You have a white response. And so we're going to be concerned here about, you probably want to get an MRI looking for retinoblastoma. Also possibly think of cataracts. Okay, ears, malformed or malpositioned ears are also associated with congenital anomalies. Microtia is a severely malformed ear. In the case of microtia, you should get a CT, and that CT is just to look to see if the inner ear is developed or not. In most cases, it won't be. Preauricular pits and tags can be familial. And the patient is usually normal. These aren't completely abnormal. As a matter of fact, I myself have a preauricular tag on both ears, just like my sister. But they can be associated with GU defects or hearing anomalies, and tags can be associated with cleft palate. I'll show you a picture of what these look like. And then you should also be able to visualize the tympanic membranes. So here's microtia, very gross defect of the ear. Here's a preauricular pit. So just like its name, it's a little pit in front of the ear. And then a preauricular tag. Mine's not that big. Okay, the nose. So you want to examine the shape of the nose. An abnormally flattened nose can be caused by intrauterine compression. But the most important thing we're looking for here is the patency of the nares. And the way I like to do check the patency of the nares, rather than sticking an otoscope up the baby's nose to look for patency, I like to just stick a clean reflex hammer in like a medication refrigerator for maybe 5 minutes. Taking the chilled reflex hammer out, and you just hold that cold metal right under the baby's nose and look for the steam collection. And if you have steam collection on both sides, you've got a patent nose. Babies are obligate nose breathers. So this comes up as really important when you have obstruction of the nose, particularly choanal atresia. And this would be noted in babies who become cyanotic, particularly during feeding. So when they're feeding, they can't breathe through their nose, and so they become cyanotic, and then they stop feeding, they cry, and when they cry, they breathe through their mouths, and they become pink again, and then they'll start breathing. That's choanal atresia. That's your typical presentation, your typical vignette of choanal atresia. And choanal atresia is the A in Charge syndrome. You should also look for nasal secretions, particularly if you're suspecting congenital syphilis. But also be very careful with those secretions because they are full of syphilis. And then looking at the mouth and throat, natal teeth can be present. They can be removed. It's not that the teeth are a problem in and of themselves. It's just we're concerned about them falling out and then becoming aspirated or choking. Epstein pearls are just epithelial retention cysts. They're usually seen along the gum margins or the hard palate. You don't need to do anything with these. These will go away within a month. Look at the tongue. Just make sure it's normal size. Enlargement is very highly associated with Beckwith-Wiedemann syndrome. Examine the palate. We're looking for cleft palate there. Look at the mandible. The mandible can be small in certain syndromes. I would say the most common that comes up is the Pierre-Robin sequence. And then subglottic hemangiomas can be present. Those would block the airway. So these are natal teeth. This is a newborn. And there's these little tiny teeth here. These are Epstein pearls. And they're on the gum margin. They can also be seen on the palate. Here's Macroglossia. So this baby's tongue is obviously large. Micrognathia. This is a small mandible, and the best place to look is just look at the chin. If the chin seems like it's small, it probably is. I mean, you see enough babies over time, you get a sense for what's normal. This is also a small mandible. Here's a cleft palate, so you don't have closure of the palate here. Here's another one. You can see on the midline here. That's another cleft palate. And then you can also sometimes see cleft lip with a cleft palate. And this will just be addressed surgically, just like cleft palate.